Now, the next important thing is, let's say the patient has come in with features or complications related to myeloma, and you make a diagnosis that this patient has active myeloma that needs treatment. The next important thing is to use the right set of tools and the right approaches in order to get the myeloma under control. So the way we use these tools depends to some extent on whether the patient is fit enough to go through a stem cell transplant. And that depends on age, depends on other illnesses that the patient might have, and of course, the preferences of the patient. Whether we treat them with a short duration of multi-drug combination, and then do stem cell transplant and then put them on maintenance with a low dose of one drug, or you do this whole thing without any transplant involved. The goal is to get patients to a point where we have very little of the myeloma cells left behind, and preferably none that we can detect with the current test that we have. So this is an area that has seen quite a bit of change over the past decade. About 10, 15 years ago, this clinical trial was designed, which looked at a combination of 3 drugs: bortezomib, lenalidomide or Revlimid, and dexamethasone, and comparing it to just 2 drugs, which is the Revlimid and dexamethasone. And what the trial was able to show that 3 drugs was better than 2 drugs, not only in terms of keeping the myeloma away for a longer period of time, more importantly, making people live longer. Now that concept has caught on, and this is not really novel in the area of cancer treatment. We know cancer cells have a very high ability to transform, as we already talked about, and become resistant to treatment. So using multiple drugs with very different mechanisms can really make an impact in terms of trying to keep the cancer under check, as this clinical trial shows. Now, our experiments of clinical trials trying to improve treatments haven't stopped there. This is a phase 2 trial. A lot of details on this slide, but all I wanted to highlight is that this trial looked at that bortezomib, lenalidomide, or Revlimid and dexamethasone, the 3-drug combination, and examined if adding a 4th drug called daratumumab, which is a monoclonal antibody, does it improve outcome in patients who are going through a stem cell transplant. And what we saw, at least as of now with the early results, is that adding that 4th drug does lead to very deep responses, meaning we are able to eradicate a much higher proportion of the myeloma cells compared to 3 drugs. Now, obviously, there are more results that are awaited to see if people actually will live longer by using 4 drugs versus 3 drugs, like what we saw with the 3 versus 2 clinical trials. Now, once the patients get that initial 4 months or so of treatment, which is aimed at trying to kind of bring the myeloma under control, what we often refer to as induction therapy, then the next step is to try and see if we can get a deeper response by using treatments like autologous stem cell transplant in patients who are eligible to go through a transplant. Now, this was a trial that was done in France, and there was a similar trial done in the US as well, both with identical results. Both asked the question, instead of doing a stem cell transplant, can we just give another 2 or 3 cycles of the same treatment with the 3-drug combination? The trial showed that if you use the stem cell transplant as part of that initial package of treatment, your myeloma is likely to stay away for longer, roughly about anywhere from 12 to 24 months longer, depending on the particular study that you're looking at. Now, these 2 studies also showed that if somebody were to just collect the stem cells and not go to a stem cell transplant as part of their first treatment, patients still live the same duration because you can still use that transplant at the time myeloma comes back. Now, what if patients cannot go through a stem cell or after the stem cell transplant? There's also the question of maintenance treatments that are often used, which we'll come to in a second. Now, another big study that was done was looking at patients who were not eligible to go to a stem cell transplant, either because they were old, often we use the cutoff of 75 years, or because they have other reasons, other illnesses that may have precluded them from going to transplant. Here we ask the question of 3 drugs versus 2 drugs. So instead of using the Revlimid and dexamethasone, can we add daratumumab to Revlimid dexamethasone and improve the outcomes for patients? What the trial did show was that the use of the use of and the daratumumab as part of the treatment in these patients did lead to the myeloma staying away for much longer period of time, what we call the progression-free survival. Here you can see the blue line with daratumumab, and then added to lenalidomide dexamethasone, and the red line with the 2 drugs. Not only did it actually prevent the myeloma from coming back sooner, in fact, it kept the myeloma on an average away for about 5 years. It also improved the survival of patients with myeloma, meaning the patients treated with the 3 drugs actually lived longer than the ones treated with 2 drugs. Very similar to what we saw with the bortezomib or the Velcade and the Revlimid dexamethasone.